Thank you all for joining and welcome to the CTSC Spotlight series. I'm Laura Parent. I'm the Director of Strategic Partnerships and Research Development at the CTSC of Northern Ohio, and we are excited to kick off. This is the third in our series, our Spotlight series. And today our topic is focusing on community engaged research and designs. We're going to look at recruitment methods from the iHERO studies. So we've got a plethora of guests with us today that we are excited to share and collaborate with you. Briefly, before I pass it off, part of the CTSC's mission is really to collaborate. You will see that as a resounding theme across our services and across what we do. And so ultimately, these Spotlight series are designed to showcase our resources and services in a way of, how are we utilizing others around us, our institutional partners, our community partners. And so that's kind of the main purpose of how we develop this and what we hope to achieve today. So I'm going to pass it off to Jerry Trubeau. He's our manager of research recruitment participation. And so Jerry, welcome, and go ahead and kick it off for us.
Thanks, Laura. For those of you who are not aware and have not met me yet, my name is Jerry Trubeau, and I'm the manager of research participant recruitment here at the CTSC of Northern Ohio. Before joining the CTSC team, I had the pleasure of working alongside Dr. Julia Blanchette at the University Hospital's Diabetes and Metabolic Care Center. Julia is a nurse scientist and principal investigator of the iHERO study, a project focused on the impact of a health insurance literacy toolkit on self-management outcomes in diverse individuals living with type 1 diabetes. I invited Julia and her research team to today's episode of Spotlight series because I believe the iHERO study is an amazing showcase of innovation in clinical research. We'll be diving into key elements of the study's design, recruitment strategy, and community partnerships, not only to celebrate the team's incredible work, but to spark discussion and to share ideas that other investigators might build on in their own research. With that said, I'll hand it over to Julia to introduce her team and begin the presentation.
Thank you so much, Jerry. I was so excited when you reached out to us. Jerry's been an incredible help with this project. We'll talk a little bit about how he's helped us in a little bit here, but I'm Julia Blanchette. I'm a nurse scientist and a diabetes care and education specialist at the UH Diabetes and Metabolic Care Center, and I'm an assistant professor of medicine at Case Western. And here today with me, we have Dr. Erica Lundgren, who is one of our co-investigators. She's a pediatric and adult endocrinologist at UH and Rainbow and also at the med school. Then we have Chantel Perez, who's one of our clinical research specialists. And then we have Anuya Conchibalta, who is one of our research assistants and you're an incoming med student at Case Western. Outgoing undergrad incoming med student. And so unfortunately, Dionne Williams and Jorden Rieke were not able to join us today. Jorden is ill and she's been an incredible support with a lot of the remote data collection components. So we will do our best to describe how she has contributed. So our objectives today are to provide an introduction and an overview of the present study. It's called the iHERO study. We will also describe some community engaged research methods that are utilized. We will describe our multi-pronged community recruitment approach. And then we will describe our decentralized study procedures for remote study participation. I'm going to try my best to give you a study overview without taking up the whole entire session because it's a long study with multiple phases, but we are so grateful to have received 3 years pending a 4th year funding from the Leona M. and Harry B. Helmsley Charitable Trust to create a financial and health insurance literacy toolkit for young adults living with type 1 diabetes. So just for a background, emerging adulthood, it's really ages 18 to 30. It's when many life transitions occur. It's a time of instability emotionally, but also surrounding finances and health insurance, especially for those living with chronic health conditions like type 1 diabetes. And as many of us know, the health insurance landscape in the United States is very confusing. And there's high potential for acute hospitalizations in this age group and also high out-of-pocket costs for diabetes medications and supplies. Also in this age group, during emerging adulthood, there's really high health insurance turnover rates, and we call that churning. So churning occurs in part due to many young adults only staying at jobs for a year or so on average, and that results in frequent health insurance changes, lapses in insurance, and that can cause a fear that one may not be able to access their insulin or diabetes supplies due to all of these health insurance instabilities. So from my clinical experiences as a diabetes care and education specialist, and then personal experiences in the type 1 diabetes community, and my research experiences, I identified gaps, and there really are no resources to support this financial stress and lack of health insurance literacy during emerging adulthood. And these are significant barriers to diabetes self-management outcomes. So we partnered with the Diabetes Link to develop, test, and ultimately disseminate this resource to fill this crucial unmet need. This is a community engaged participatory action research project. So we have co-investigators from a community partner, which we'll get into in a minute who that is, the Diabetes Link. And we have diabetes community members involved in all phases of this project. During the first phase, we developed the toolkit itself with the Diabetes Link and diabetes community members. And the next part of the study, which is where we are now, is we're testing the efficacy of that toolkit in a randomized controlled trial. And we're enrolling young adults ages 18 to 30 from across the US to ensure that we have individuals from Medicaid non-expansion states. So of course, we're recruiting from our UH population, but we also are recruiting from the greater type 1 diabetes community across the nation. And really importantly, we are ensuring participation of underserved, publicly insured, and racially and ethnically diverse individuals from both Medicaid expansion and non-expansion states to ensure the clinical validity of this toolkit and to make sure it's really widely acceptable for the population we're hoping to help. So just to reemphasize, this is a multi-phase project. The first phase, which is complete, was to develop the toolkit itself. Now we're testing the toolkit. We're testing its efficacy on financial stress levels, health insurance literacy, quality of life, glycemic outcomes, and transition readiness in a 1-to-1 randomized controlled trial with 192 young adults from across the country. And then the last phase, which we're not really going to get into today, but it's important for you to know as it's part of our community-based participatory action research project, is we aim to launch the toolkit free of charge back to the community and to ensure there's no issues with engagement and to ensure it's sustainable long-term. So first, I'm going to kind of get into how this partnership, first who the Diabetes Link is, and then how the partnership developed. So the Diabetes Link is the only national organization for young adults with diabetes by young adults with diabetes. They incorporate real-world lived experience into everything they do. And their mission is to empower young adults with diabetes by providing access to peer support, connections, and resources to thrive. And so their three main areas here are the peer support, education, and leadership development. And so where their strengths have really been essential to this project are with the education, their resource hub. That's how we are implementing the toolkit itself, but also their peer support network. They have access to such a large national community of folks, but they also have connections to other community organizations that have been pivotal in our recruitment efforts as well. And so each year, the Diabetes Link conducts a community needs assessment. And so what they identified a few years back was that they needed and a few years back was really when COVID was hitting. They needed a digital way to connect their peers, as a lot of their in-person programming was no longer realistic at the time. And so what they found was that they needed some digital method to disseminate information that engage young adults. And so that's where they came up with their resource hub. So their resource hub, you can go to it now. You can't see the toolkit that we've developed now on it, but you can go to it now if you wanted to. It's called the Diabetes Link Resource Hub. To access diabetes education, they have multimedia assets available. So they have blog posts, videos, infographics, guides, scripts. all sorts of content, and it's all developed with young adults with diabetes, and then clinically, it's looked at clinically by experts in the field. And so one of their tests, they called it their beta launch, they launched these 4 videos on insurance, as they had identified insurance as one of the content areas that was lacking resources. And this was back in 2020. And so the insurance videos in particular had a really high reach, higher than they expected. And so at the same time, I was doing my postdoc at the University of Utah, and I had worked with a community advisory board to develop and pilot a financial and health insurance education toolkit. There were 10 micro videos, and the main specific aim was to examine the feasibility and acceptability. I did look at preliminary efficacy of the toolkit, but I had such a small sample size as it was my postdoc that my main aim was really to look at the feasibility and acceptability of this digital resource toolkit, and if these young adults with diabetes found it useful, engaging, and if it was something that we could make large scale. So I did find the toolkit to be feasible and acceptable. And so I had these 10 different content areas that my community advisory board came up with. And then the Diabetes Link had these 4 different insurance videos that they came up with. And so, I had been volunteering with the Diabetes Link for a few years, working on building my relationship with them, since they engage the young adult diabetes population, which is really my research population. And so I had volunteered with some of their leadership programming as a next gen fellow mentor for a few years. I presented at some of their leadership training meetings for the young adults. And then I had really focused on building relationships with their staff at some of the diabetes conferences. And we'd even co-presented a couple times on resources for young adults with diabetes for self-management. And so then in 2021, we realized our shared interest in developing resources for health insurance and financial stress for this young adult population. And we actually, in 2021, wrote a grant together and started planning our project. And now here we are running this 4-year multi-phase project together. So this is a fully community-based participatory research project. So, the academic research team here at UH and CASE and the community are sharing equal decision-making and ownership in everything we're doing together. So I'm not going to get too into this because we have a lot more to share with you, but together our first step was to develop the enhanced toolkit, because we had both piloted our own kind of mini toolkits. So we wanted to develop a bigger, better, large-scale one, and we wanted to ensure that it met the needs of racially and ethnically diverse individuals, but also those that are Medicaid insured or uninsured. And so we had a community advisory board with 10 members. We had 100% retention rate. So everyone on the community advisory board was either a racially or ethnically diverse young adult with diabetes, or a young adult with diabetes on Medicaid, or who was previously uninsured as a young adult, or a financial or insurance diabetes expert. We had a series of meetings where we really worked with the community advisory board to make sure that they approved every single part of the toolkit. It was a lot of work back and forth, and the Diabetes Link took a really big lead on actually creating the content that the community advisory board had recommended. And then we took their feedback and kept going back and forth with iterations until we came up with what they approved. So there were a bunch of different content areas that the community advisory board had recommended, basically focusing on either health insurance education, financial education, health system navigation, or healthy coping and problem solving with diabetes. But another thing that was really important was we wanted to make sure that we not only had the appropriate content, but that the toolkit itself would engage racially and ethnically diverse individuals and those on Medicaid or uninsured. And so the themes that we also had to weave throughout the toolkit that we produced, where we had to ensure we address clinician bias, We had to address how to build community and seek support, how to empower and address mental health impacts of type 1 diabetes, acknowledging health disparities, and then also ensuring cultural and family dynamic representation, racial, ethnic media representation, and then healthcare provider representation. So our finalized toolkit has 13 modules. It's multimedia. It has 13 videos, and then there's other digital resources that go along with it, like scripts to talk to your insurance, budgeting worksheets, and some other really cool tools. So I'm not going to play the sample video as we don't have time, but I just wanted to show you what it kind of looks like when they're watching the video pieces. This is just like, I'll just play it for like 5 seconds. You can see here's a young adult with T1D who's talking about her own experiences. And then this is just what some of the other resources look like. Okay, so now I'm going to pass it on to Dr. Lundgren to talk for a couple minutes.
Yes, everyone hear me okay?
Yes.
Okay, so just real briefly, I'm going to go over the RCT portion of the study. So now that we're in phase 2, we are aiming to evaluate the efficacy of this iHERO toolkit on health insurance literacy, financial stress, and diabetes self-management among our emerging adults aged 18 to 13 years who have type 1 diabetes, just compared to usual care. And the other goal of this is to ensure that we have a very, very diverse population. So at least 50% of study participants recruited will be on Medicaid health insurance plans, and half of our patients will also be racially, ethnically diverse. The methodology is that this is a longitudinal waitlist control randomized control trial. The intervention group receives the toolkit for a 30-day viewing period via the Diabetes Link resource hub that Julie just showed us. And then the control group is observation only. That was the best comparator of usual care based on prior studies in this population. The intervention is completed in an asynchronous format remotely from their own mobile devices or computers. And then the next part will kind of show you the timeline for this. So at baseline, we're collecting demographics. Folks are filling out lots of different questionnaires via REDCap. And then they also collect A1C sample at home. And then they will, of course, get randomized. The intervention group has that 30-day access to the toolkit. Control group is usual care. And then at the end of that period, there's exit interviews. That's kind of first time point after baseline, and a bunch of questionnaires for both randomized groups. So that's the end of the intervention. But then there's follow-up longitudinally at 6 months, where the same questionnaires are completed again, and at 12 months, same questionnaires are completed again, and at both time points, A1Cs are collected at home. And then afterwards, there is, after the completion of 1 year, the control group is going to have access to the toolkit, and we have some descriptive data we can collect on that group at the end as well. So how we're randomizing to ensure that we have a nice diverse group here is our goal number in the study is 192 emerging adults with type 1 diabetes. We're first stratifying our randomization scheme by insurance type, either Medicaid and uninsured or private, or not answering that type of insurance. And then after that, we also further stratify by race ethnicity, namely white, non-Hispanic, and other diverse non-white or Hispanic ethnicity. And then we randomize to intervention or control. So far, we have 122 volunteers enrolled, 120 were randomized, as 2 withdrew. 66 are in the intervention group, 54 are in the control group, and 43 of those 66 have completed the intervention and 22 have completed the optional exit interview.
Okay.
I will take over to Julia.
Awesome. Well, thank you for that. So now we're going to talk a little bit more about our equitable recruitment strategies. So we have had to change the recruitment plan a few times, which was expected. This is community engaged research. It's normal to have to kind of change things as they're happening, to try out different methods, and if things aren't working, to kind of revisit our methods and look at how to change things. So initially, we thought that we would partner with clinic recruitment sites, and that we had strategically partnered with these collaborators. So these sites have had a lot of success with enrolling racially, ethnically diverse, Medicaid insured and uninsured young adults with diabetes and engaging with them in other research. And so we have CHLA, we have University of Florida, and CHOP. And it takes a really long time to do in-person recruitment. They are amazing. They have gotten us so many participants that are still engaged in the study. But in-person recruitment takes a long time. And so we had aimed to do recruitment in 1 year. We've now extended recruitment into a second year. And so now our new goal is to complete recruitment by the end of July 2025. And so we have to recruit 70, well, it's actually less than 70. This was a few days ago. So I think it's like 65 more individuals now. But we really took a look at where we're getting the most individuals who are either publicly insured or racially or ethnically diverse. And so a couple of the clinic recruitment sites have pulled the weight with those recruitment referrals, but we also have a community partner, Thrivable, that's one of Diabetes Link's partners, and they have access to a large population of racially, ethnically diverse, and publicly insured individuals with diabetes, and they've been able to pull some through as well. And they just started sharing some of the materials. So we kind of had to revisit things. We're now focusing our efforts. Oops. I don't know where my slide went. Hold on. Okay, sorry. We're now focusing our efforts kind of in these highlighted areas. And then as you can see, I wanted to point out the Diabetes Link. They have this great online network, and we suspected that we would be able to get a lot of participants really quickly through their online network, which we did. We got about 50 within a few days. However, they were mainly white, non-Hispanic, privately insured individuals. So we're really refocusing our efforts on more in-person recruitment, and then having the Diabetes Link partner with some of their other community organizations and young adults who have networks of racially and ethnically diverse individuals to continue word of mouth recruitment and recruiting through the community. So this is kind of just like an overview of how our recruitment is working. So we have our recruitment partners from the community, and then we have the clinic recruitment. So I do want to talk a little bit about UH recruitment. So what we've done at UH, and as you can see, I'm going back to this slide for a minute. We have recruited the highest number of participants from the clinic so far. But what we've done at UH is we did MyChart recruitment. We were one of the first studies to utilize that at university hospitals. Thank you, Jerry, for your help with that. And we were actually able to target individuals that were on public insurance or racially or ethnically diverse in their medical record to give them the messaging about more information about the study if they were interested. I just wanted to point out, we don't use clinic text messaging, but a couple of the sites, CHLA and CHOP, have reliant IRBs. And so if that's what's been approved for that site to refer them to us, they do that. But we use some other methods, which I'll get into in a minute. And this is just our UH recruitment flyer. Some of the other sites are sharing this flyer as well. And then it's been shared kind of through social media channels as well. And then our IRB approved the Diabetes Link social media posts, which you can see the Diabetes Link developed themselves because they know this population. They're kind of fun. catchy. And then this had links to the interest form if individuals wanted more information about the study. I just scrolled through this one really quickly. I didn't mean to, I'm sorry. So you can see it for a minute. So now I'm going to get a little bit more into how we're doing this all remotely. So what's happening? So I kind of just went over all of the different ways that participants can be referred to us, or so they can be referred to us through the online community, through one of our partner clinical sites, or they can be recruited through the UH population. And so once that happens, the participants can go to our REDCap screening form. It's a UH REDCap form. Then, if participants seem eligible from that pre-screening form, the UH study team will contact the potential participant, confirm the eligibility, and then set up an enrollment visit. And then the enrollment visits are done by the UH team on UH Zoom, and we are doing the virtual consent on those calls. And then one thing I wanted to point out is, the participant does have to show a valid state ID or passport of some sort to verify their identity. And then after that enrollment visit, all the rest of data collection is remote. And so we've had pretty good, we're not missing a lot of data. We've had pretty good attrition. And I think that's because we're using Twilio, which is another tool that Jerry Trubeau introduced us to. And this is really, Jorden on our team really has done a lot of the work with this. So I wish she could be here to present it. But since we're using REDCap for all of our data collection, except for the A1C, which we'll talk about in a minute, we're using the Twilio add-in. And so what happens is participants can either opt into text messages or email for how they want to be contacted. And so if they're opting into text message, we can send them text message reminders through REDCap. If they're opting into email, then they get the same type of reminder to an email, also through REDCap. It's not two-way communication. So the participant, like if they try to respond, like it doesn't come back to us. The only way they can respond back is we are able to tell them, like, have you completed your home A1C test, and put it in the mail. Press 1 for yes, 2 for no. We can get like a 1 or a 2, like for a yes or no response, but they can't actually send us information besides that back. So it's just one way, and it's working pretty well. And we're able to then reach out to folks that need additional follow-up from there. So Twilio one-way pushes work great in this young adult population. And so now we're going to talk a little bit about this home collection A1C kit. So we are using these Minnesota A1C kits. It's a capillary A1C. Essentially, the participant takes a capillary finger stick, puts it in the little collection tube, and then mails it to the Minnesota lab. And then Minnesota analyzes it and sends it back to us. The reason why we're using these kits in particular is because these kits that are processed at the Minnesota lab are they're the most reliable and valid way to collect A1C at home. So there's a lot of kits. You can get these like A1C Now kits or other ones that show like an immediate A1C. But these that are actually processed in the lab are more reliable. So there's been a lot of research to validate these. So that being said, we were a little bit worried about sending the kits to these young adults who live across the country. What if they move over a year? So we do ask them for where they'd like us to send their A1C with each kit. So they get that as part of a survey, a REDCap survey. And then they do get these full instructions for the A1C kit that come with all of the parts. So we send it to the participant then has these instructions, all the parts, and then the participant sends it to the Minnesota lab. The Minnesota lab then securely sends us the result. This is just showing the instructions. So I think it looks straightforward. I've personally participated in a study back when I was maybe 22 or 23 that use these same kits, and I didn't have a problem with it, but we started finding out that a lot of our participants needed additional instruction. So we've now added some pushes through Twilio to give more direct instructions, more clear instructions than we had initially set up. These are just more pictures of how the collection works. And then there is this form that the participant receives. So like we fill out part of this, the participant fills out when it's collected, and then they put it in with their kit when they send it to the Minnesota lab. So then we were wondering if some of the test kits were getting lost in the mail. And so what we ended up implementing is this one verification question. So like a week or so after the test kits are sent to the participants, they get this question from REDCap: have you completed your A1C kit and put it in the mail? They'll either say yes, no, or I have not received an A1C kit. So if they say no, or I haven't received it, we then reach out to them to make sure they don't need more assistance. And then this is just what it looks like on our end when our team is entering in the A1C results. Okay, so with that in mind, I, during my postdoc, had collaborated on a study with one of my mentors, also the young adult type 1 diabetes population. She used these A1C kits from the Minnesota lab, and we found that it was really hard to get this population to send them back. And so, you know, A1C is still the gold standard glycemic outcome metric for clinical research studies. So we wanted to include A1C. Obviously, we couldn't do lab A1C as this is a national study. So that was kind of our best option. But at the same time, I thought, well, let's see how many of these participants are wearing continuous glucose monitors, and we can give them the option to upload their continuous glucose monitor data if they'd like to. And we didn't make this required because to get a continuous glucose monitor requires insurance coverage and often cost, and we didn't want to exclude anyone who didn't have access to CGM. But what we've found so far is that 86% of our participants have actually are wearing CGM and have uploaded their CGM data for us. So we are getting a pretty substantial amount of this CGM data, even though it's optional, whereas we've only had about 74% of the participants send us back the A1C kits, despite all of these efforts with sending them additional Twilio pushes and everything. So I'm going to give this back to Dr. Lundgren. So Anuya is actually on the call right now too. This was her abstract, but Erica's going to talk a little bit about what our team looked into to further understand barriers with A1C, these A1C kits. And then we're also going to talk a little bit about, do we need to use these A1C kits in the future? Can we maybe make an argument to also look at these continuous glucose monitoring outcomes? So I'll pass it back to Dr. Lundgren.
Yeah, and actually, since Anuya is here, she is the first author on this abstract.
Not to put her on the spot, but
I asked her in the background, so she said,
okay, cool.
Do you want to summarize it? And you this is your baby.
So basically what we were looking at is kind of just going through the interactions we were getting that we were documenting in REDCap and trying to see if we could find any trends or themes that were kind of popping up with what people were having challenges with or what they were reaching back out for further clarification. So we ended up getting quite a bit of correspondence over REDCap with over 102 interactions. And we found that these weren't all distinct participants, so they were only unique to 37 people, but it does show that sometimes there can be repeated challenges or repeated questions that come up throughout the process. And so something we found that could be helpful for future studies that want to use these remote A1C kits is that it's helpful to send out clear information on how to use the kit. So something that Julia was talking about with sending out more information over Twilio and things like that. And also sometimes there were issues with mailing and tracking. So people weren't able to see where their kit was on the way to them, or once they mailed it out, we were having trouble tracking it as well. And then sometimes there were issues with collection results and storage, but this was often a really rare occurrence. So most of the issues just came from understanding how to use the kit and being able to track their kit.
Awesome. And since we also have CGM data, we wanted to look at another aspect of these A1Cs that we're collecting and compare them to GMI, or glucose management indicator. We know that can approximate A1C. It's calculated whenever someone's utilizing CGM consistently from at least a 2-week download. And we know that getting A1Cs coming into clinic visits can be a barrier for this age group. So we wanted to compare A1C and GMI. We know that there is not 100% concordance between these two. They are measuring different things. And prior literature showed that, especially in those who have more time above 180 or time above range, that there's less concordance. So we wanted to particularly look at this correlation and the influence of having more time above range on that concordance in our age group in the iHERO study. So we just did a cross-sectional comparison looking at our available baseline data, comparing again those who had CGM data that they agreed to upload. And then we looked at the correlation between GMI and A1C and looked at the baseline demographic and glycemic data. There were 96 participants enrolled at the time that we pulled this data, with 60 or 62% with usable CGM data and A1C results. The correlation between the two was statistically significant, the correlation of 0.875. And then table 1 is not on this slide here, but if I can pull it up and just basically summarize it for you. In those who were meeting time above range goal, which was 31 of this group, or half of the group basically, compared to the group that was not meeting time above range goal, age was close to 23, 24 on average, so similar. We had a higher group that was female, 83 versus 65%. We had a predominantly white race that had CGM data. We couldn't, because of the breakdown, that we couldn't do a statistical comparison there. But type 1 diabetes duration was similar, about 12 years. Majority were using Dexcom, actually Dexcom G6, with about a quarter using the G7, and only a handful of people using the Libre 3. And then CGM wear time was very high in both groups, 97% and above, really. Not unexpectedly, those who were meeting the time above range goal of less than 25% were more likely to have a higher time in range, or had a higher time in range, had a lower average glucose, and had a lower GMI and a lower A1C. What was really interesting, though, is that there was no difference among these two groups in terms of the GMI A1C difference, which on average was 0.3 percentage points higher GMI versus A1C. So pull this back up. So basically what we found was that in our group, at least, GMI and A1C were highly concordant. Really suggests that this is a useful tool, accessible tool that can approximate A1C outside of the clinic setting when we don't have access to their blood to actually measure an A1C. And then we're going to continue collecting data to try to understand the factors that may actually influence this concordance.
And we just wanted to thank everyone who's been involved so far. As you can see, there's a lot of people who have been involved. We have students, we have a lot of community members from the Diabetes Link, and then we have a lot of research team members here at UH. And we've just been really grateful to be able to do this work and to be here. And so we also wanted to thank our funder, the Leona M. and Harry B. Helmsley Charitable Trust. And we have some time for questions.
Thank you guys very much. If anybody has any questions, feel free to come off mute and ask them or put them in the chat.
There's lots of people I know here, so somebody better ask.
Valerie, you raised your hand.
Hi, amazing presentation. And Julia, I'm just so proud of the work and amazing work that you are doing as your former dissertation chair. What you've done beyond your dissertation is fabulous. I just had a quick question for you. I was very interested in your phase one and how you did the community advisory board, and you had to develop this toolkit, and you were saying there's a lot of back and forth. So what are your pearls of wisdom for others that are also going to be going about this line of research and
Yeah.
developing something?
Thank you so much, Dr. Tully. So that's a really good question. Also, thank you for being here and for supporting this. But the community advisory board to develop the toolkit I think it was more involved than I had anticipated. So it took a lot of time on everyone's end. And um, fortunately, we had enough money allocated and incentives allocated as the community advisory board members had agreed on, but it did take extra time on their end as well. And so what we ended up doing, so we had planned to do six meetings on Zoom that were 1 hour long, and we had to change that plan as we were developing the toolkit. We ended up doing a couple of the meetings in more of a like written feedback format to give the community advisory board a little bit of a break because it was becoming a little burdensome. And we also reminded them, like, you're a volunteer. If you're not required to attend all of these meetings. So we just wanted to make sure we had at least 70% representation at each of the community advisory board meetings because it was taking a lot of time. So that was really important as well. And then also just being really considerate and understanding of our community partner and the time and work that they were putting into it. They were under a lot of pressure as well to develop the materials to then get them back to the community advisory board. So as a partner, I really did put in a lot of effort to make sure I could assist our community partner in development as needed. So that's more about the pearls than the process. The process would take a long time to explain, but I hope that answered your question okay.
That's great. Thank you very much.
So I have a question. I am actually a first semester new MPA student, and I'm working on 2 projects. So I noticed that you had a basically social media toolkit to be able to recruit your study participants. How effective do you think that social media was for utilizing this method with young people? Because the 2 projects I'm working on are dealing with children with asthma and their families. So actually I kind of can congruently see those families being kind of like that. So how did your group feel about the social media campaign and how effective it was to get you the study group participants that you desired?
Yeah, I want to give others a chance to answer the questions too. Chantel or Anuya, do you feel comfortable answering that one, or do you want me to take that one? You want me to take it? Okay, I'll take it. So, our community partner, the Diabetes Link, is really the expert in social media engagement with this population. I called on Anuya because she was a volunteer with the Diabetes Link, so I thought maybe she wanted to participate, but that's okay.
Add in a little bit. I know
Yeah.
that I follow Diabetes Link on Instagram, and I did see quite a bit about our study, which was super exciting. So I know that it's definitely reaching the populations that we're targeting. And also, I would say that just from the recruitment numbers, I would say that Diabetes Link has been one of our biggest sources for participants. So I'd say in that regard, it's been really helpful in meeting our targets, even though it might not be as diverse as what we were initially looking for.
Yeah, and so when I did a mini analysis to kind of take a look at where our participants are being referred from, we ended up having to kind of make a cutoff with the Diabetes Link resource or the Diabetes Link method because we were getting so many folks interested, but they're all white, non-Hispanic, on private insurance from that demographic, which was what we had anticipated. So they kind of like backed off on on sharing the campaign because we've really reached that that cap on those individuals. So it's very effective at getting quick engagement, but it may not represent the community as well as we need it to. So.
Awesome. Does anybody else have any other questions before we wrap up? If not, feel free to reach out to us afterwards if anything comes up. So to sign us off, feel free to take a look at the CTSC link tree for resources on how to become a member, events, podcast episodes, webinars. We also have a new participant-focused link tree with resources for research participants. We're also linking our podcast episode with Dr. Erica Trappel on relationship-based recruitment that touches on many of the same topics as discussed today. So feel free to take a look at that as well.
And as we wrap up again, we just want to thank you to Julia and her team. We appreciate your sharing and, you know, how effective this has become for you. So, you know, thank you again. We will send out the link for the recording once this is all wrapped up. And next steps would be register for our next Spotlight series. So Dr. Grace McCumsey will be presenting on research integrity on May 13th. You can scan the QR code, or of course, when you get that email after the seminar today, you can have access to that. If you have any questions for Jerry Trabeau on recruitment services, so either social media recruiting, which we're kind of diving into sort of newish, right? We're
Yep.
working on getting that and working with IRBs to make sure that, you know, it's all approved and all streamlined for access. And then, of course, become a member of the CTSC, stay up to date with funding, events, and all of your recruitment needs. So thank you all for attending, and we look forward to seeing you the next time. So take care.